Okay.
Okay, it should be recording.
Okay, everybody's joining. Good morning, everybody.
Morning.
Miel, how are you?
Good, how are you?
Very well, thank you. Morning, Gab.
Morning, Jackie.
And we've got Morris. Hello, Morris, and Troy. And I think somebody's connecting to audio there. And Nicole. Good morning, Nicole.
Morning.
And we've got Taffy's just joining as well. Okay. So I just wanted to let you know, firstly, that we are recording this webinar. We make it available afterwards to all our ECA partners. So I just want to make sure that was okay with everybody. Yeah, Josh does amazing things with cutting it at either end to make it all fit into the right thing. So we might kick off with Hepatitis C Surveillance 101. This series of workshops, so this is the fourth of our ECA workshops, and the topics have actually come from our partners who have told us that they wanted additional information. This workshop came after our workshop series last November, where Anna Wilkinson presented the annual surveillance report. And there was lots of questions and comments about, wow, there's a lot of information. I'm not sure if I understand it all. And I really want to be able to understand it because surveillance is such an important part of monitoring our elimination efforts. So my name is Jackie Richmond, and I'm the manager of the Workforce Development and Health Service Delivery component of EC Australia. My colleagues and the stars of today's show are Anna Wilkinson and Josh Daw, and they'll be doing the presenting. So I'd like to begin by acknowledging that we're all on different lands today. And for me today, I'm on the Wurundjeri land of the Kulin Nation, and I'd like to pay my respects to the Wurundjeri people and to their elders past, present and emerging. So 101 surveillance, we have a couple of slides and we've got question and answer slides. So please feel free to flood the chat with questions. Feel free when we come to those question and answers, if you want to take yourself off mute and just ask those questions again. The benefit of a smaller group is that we get to have more interaction. So over to you, Josh.
Thanks, Jackie. Yeah, just to reiterate that, we were worried that Hep C surveillance might get a little dry, so we encourage as much engagement as possible. So if you feel like you want to post something in the chat or take yourself off mute, feel free. Cool, so I'll kick it off. All right, so what is infectious disease surveillance? At its core, infectious disease surveillance includes the ongoing collection of population level health data. And it forms a key component of infectious disease epidemiology in general. Infectious disease surveillance has existed for a long time, almost 2 centuries. It started with the outbreak of cholera in London with John Snow, where the source of the outbreak was traced back to the handle of a water pump. And in Australia, it's existed for almost 2 centuries as well. Mandatory disease notification started in Australia in the mid-19th century, so it's been around for a long time. Since its inception, the fundamental role of disease surveillance has really been around identifying and responding to outbreaks in infectious diseases. And over time, infectious disease surveillance has become more and more sophisticated and has involved more and more people and has more and more systems, including labs, healthcare professionals, and community members. What does public health action in infectious disease surveillance look like, though? Well, it really depends, like a lot of things. So the actions taken in response to infectious disease outbreaks depend on lots and lots of different factors and contexts, including the timing of the outbreak, the size of the outbreak, the population at risk, the infectiousness of the disease, and the mode of transmission, and that's just a few of the factors. We can use the data, the surveillance data, to make action at an individual level. So a recent example would be the immediate action that's taken for every COVID-19 case that tests positive and is notified. Or we can make action at a population level by shifting policy and identifying and responding to the needs of priority populations, such as introducing universal screening for populations at risk in clinical settings might be an example. Why is it important in hepatitis C, or what makes it different in hepatitis C? Well, there are a couple of factors that I'm sure we're all pretty aware of in hep C that might make surveillance a little bit different in this space. The first is the introduction of DAAs in 2016, which completely changed the landscape of hepatitis C care in Australia. And it means that we need to be able to monitor our progress towards elimination targets and the effectiveness of the DAA treatment. And the second thing is the elimination targets themselves. So the Australia's elimination goal by 2030 is measuring our progress towards that goal and seeing whether or not we've achieved that is determined by having good quality surveillance and being able to effectively measure our baseline and see where we started, track our progress along the way, and then see where we end up. People can contribute to hep C surveillance in many different ways, and it stretches all the way across the hepatitis C sector and includes disease notifications, but it also includes stuff like participation in surveys such as the annual needle and syringe program survey. I'm going to pass over to Anna for these next two slides. So this is around some different types of surveillance that we have and what they look like in action.
Thanks, Josh. Welcome, everybody. If you haven't met me before, my name's Anna Wilkinson. I'm here at the Burnett Institute. So I'd like to acknowledge the traditional owners of the Wurundjeri people, which is where I am today. Okay, so we want to talk about some types of surveillance data that we know, and you would have probably heard of these and some examples of these. I always think it's interesting to think about the ways essentially that we're nosy. Surveillance is essentially being really nosy and collecting information about people. And that might be in a way that you view as positive because we care and we're bleeding hearts in public health and we want to do something, or because we just generally want information on other people for perhaps purposes that aren't very nice. But let's go with the nice option. Here's the ones that you know about. The first one is a surveillance type that we know, which is what we call passive surveillance. And this is notifiable diseases, which then translate to notifications. So you would know that this is generally a state-based system. It does feed then into a federal-based system of collecting data. This data is publicly available. So you can go onto a website and have a look at how many notifications have been received for a whole bunch of diseases that the government has decided they want to know about, because it impacts other people, it impacts the health system, because we have this public health system way of operating, they want to have some information to then act on this information. And as Josh was saying, what they do with that information really varies disease by disease. Generally, what they want to look for is a trend. So they're looking for how many notifications they get in particular time periods and whether or not that's changing. You then have an enhancement of those notifications. So where it's been a decision that's been made that they want some additional detail about that person who has that particular infection or particular disease, because they want to do something a bit more about it. Sometimes they do something a bit more about it, sometimes they don't. They just want to understand a little bit more detail about a trend in an infection or a trend in a disease. So this is enhanced notification. Next slide, thanks, Josh. We then have something called sentinel surveillance. And you may have heard of this, or you may not have heard of this word, but you will know the concept. And sentinel surveillance is essentially a canary in a coal mine approach to surveillance. So when you want to know about a large place or a large group of people or a large thing that's happening, but you can't have the money or the time or the resources to measure everybody, so you choose particular people or particular places to collect data from, and you hope that your choice of those places is informative enough that it tells you about the whole population. Sometimes you might make that choice on a guess. Sometimes it might be an educated guess, or sometimes it might be a very educated guess. So you might know about sentinel surveillance, the one I always think of immediately, maybe that's just how my brain works, is chickens. So you might know about the bird surveillance. So they pick out particular birds in bird populations to find out if they have infections. This happens again, something maybe a bit more relatable, which is GPs. So we've got GP sentinel surveillance. We've got syndromic surveillance at A&Es to try and pick up things before they get really bad. So they're an early warning system. Sometimes we act on them immediately. Sometimes we just look at them for trends over time to see what is maybe an underlying trend in a population. There is behavioural surveillance. So the previous surveillance systems I've mentioned really focus on testing and test results in my mind, but there's behavioural surveillance as well, where we want to know how people are acting, because that may influence whether or not they are getting infections or not getting infections, or at risk of infections or not at risk. And so we want to understand behavioural trends. So there is behavioural surveillance, and generally that's the very systematic periodic collection of some questions. So it's all self-report data, but it can be very informative for understanding trends and what's happening. Then there's a slight enhancement to that, which is biobehavioural surveillance. So you might do a behavioural questionnaire, and then you might have the capacity of some extra dollars to collect some biological samples to go alongside this. And this really just enhances that understanding of behaviour by adding in a test result as well. So this brings together the two things that we've talked about, which is a surveillance of test results and infections with some behaviour. You can actually put those things back together. They tend to be done periodically as well, again, to understand trends over time and see what is happening as you move through time to a particular infection, particular behaviours, so then you can act. So that's a bit of a brief overview of all the different types of surveillance that happen. All of those types of surveillance happen in Australia. They happen consistently in some other countries, but not in all countries as well. I'll hand back to you, Josh.
Great, thanks, Anna. All right, now we have an opportunity for questions and comments, if anyone's got any. I know that Jackie's just put a question for Anna in the chat, which I'll read out. Anna,
except I've stopped up the typing. It's meant to be.
Fine, I can work it out. This is my interpretation of your question. Anna,
so now we just interpret.
Are disease notifications in BBB standardised across Australia?
Yeah,
I know there are differences between jurisdictions and hospital-acquired infections.
For case definitions, there is standardisation. So I know we have Robert Kemp on the call, so he probably knows a lot more about this again than me, but there is a CDNA, which is a national kind of group that decides on case definitions. Now, this is what they apply to the data they then collect. So you might collect data in a way that suits a state, but then you need to apply standardized case definitions to that data to make sense of it nationally. So if you want to say for hepatitis C, you may know we have two case definitions, newly acquired and unspecified. Those case definitions are standardized, so we can bring together data nationally and it makes sense. States, however, can make their own decisions about, for example, which disease is notifiable and what information they collect about a particular notifiable disease. My understanding, and I'm not involved in it, is that it's quite a cohesive network. And so there's a lot of communication and a lot of collaboration. But I think states additionally, as we are becoming more and more aware, do have a lot of autonomy about their collection of notifiable diseases.
Yeah, I find that really curious. And, you know, I just assumed everybody was the same because of the CDNA definitions, but it's this infection prevention and control work that I'm doing that some report, you know, C. difficile infections, others central line infections, you know, and there is that diversity.
Yeah, correct. And I think it's nice because some places, so for example, I used to work in Queensland where there was leishmaniasis. And it's like, well, why do I need to know about leishmaniasis? But actually it's very important when you work in far north Queensland that it's a notifiable disease, that you're able to put your own actions in place because it is important to that place. Absolutely. So notifications have a very detailed, remember your basic epidemiology, time, place, person, notifications need to be tailored to your own time, place, person so you can act appropriately as the government that helps us to get through public health.
Yeah, that's great. Thank you, Anna. Gab's got a great question here. How do you decide which infections get what type of follow-up? It doesn't always seem to be based on risk.
Again, I think that's a state-based decision. And as you would know, there's very robust conversations happening in the space of viral hepatitis, so B and C, as to what you do with those notifications. So there's a nice report that's come out of the Burnet Institute with colleagues, and Tafi's on the call, so he's involved in that, as to what is happening in the States and what could we do. So there's those actions of notifications are state-based decisions. Hopefully we get some national coordination as well.
And Troy's also just asked about that case definition. Are there any plans for a Hep C reinfection case definition to be included in surveillance?
Don't know. I genuinely don't know. You would have to kind of fit the case definition of new infection. So the new infection case definition would apply to a reinfection anyway. So you would just be classified as a newly acquired infection if you had evidence of previously clearing your infection. But that's something, I think that's a good question. I think the question, Troy, is a little broader at the moment, which is, are we interested in reinfections for surveillance? That's a very resource intensive process. And to be honest, is that the most important thing that we put our resources in? Some people will argue no, because why do we need to know about reinfection?
Yeah,
so when you resource limited settings, sorry, I was just going to say, no, you have to remember that surveillance is resource limited setting. In a resource limited setting, what do you need to know about?
Gab, you've come off mute. Did you have a question?
No, sorry.
No, I thought you were poised to say something. Tafi just asked, can we conduct biobehavioural surveillance in a passive, active sentinel format? Tafi is just proving that he's been listening. He's used every single type of surveillance in one sentence.
Tafi, I think that's what the kids call flexing. I don't think you need to put every single word in a sentence and ask if we can do it. You're next door to me, so if you want to be a smart aleck, just come into my room and be a smart aleck. Josh, I'll hand back to you for time, I think.
We love you, Tafi. That's why we tease you. Okay, I will share my screen again.
Thank you for those fabulous questions. That's great. Thank you,
everyone.
Keep going with the...
Cool. I think I've done this right. All right, so measures of disease frequency. So what is it we're actually trying to measure at the end of the day? So today we're going to cover two of the main measures of disease frequency that we use in surveillance and in epidemiology in general. And that's incidence and prevalence. A lot of people, I feel like there's a varied amount of knowledge around incidence and prevalence. Most people are pretty clear on what prevalence is, but I have heard people use incidence and prevalence interchangeably and they're not the same thing. So I think clarifying the difference between the two and what they're telling us is really important. So incidence is new cases, and using incidence, we can look to see, we can estimate risk, and we can also estimate how quickly cases are developing. With prevalence, we have an estimate of existing cases. So what proportion of the population has the disease or outcome? So what is the burden of disease in a population? If we use an example of hepatitis C antibodies for prevalence, we know that people have antibodies for a very long time, very, very long time. And so prevalence in the short term is unlikely to decrease for hepatitis C antibodies, where incidence may not decrease as quickly as people become exposed to hepatitis C. So here's a conversation starter. This is, I'm not sure how well this is going to work, but this is if everyone would like to pop something in the chat or take yourself off mute, and we can just think about how, whether we would use prevalence or incidence in monitoring an outbreak, whether we'd use both, what our thoughts are around that. Please, someone post something in the chat.
Just put poor Josh out of his misery. What do you think? Prevalence or incidence to monitor an outbreak? Thank you very much, Gab. So we've got one for incidence. Yeah, was also incidence.
I'm going to play devil's advocate and say both, because you could use incidence to look at specific hotspots of where new infections are happening, but then you could look at your prevalence overall to see what the proportion of the burden is on that from that incidence.
I think that's
Okay.
reasonable.
Yeah. Is there an answer, Josh?
Not really. It's more of a conversation point.
Oh my gosh.
I mean,
Oh.
I think probably incidence is probably what we would focus our attention towards, at least I would. But I think that there's not really a one size fits all approach to these types of things. And, you know, the more information that we have, the better. And we can definitely make use of a lot of it. And there's a lot of situations where, in fact, the majority of situations where we don't really have reliable estimates of incidence. And so we still have to use prevalence as a sort of proxy measure or something to look at instead. But I just thought it was an interesting thing to ask and see what people's thoughts were. We've got a couple more conversation starters as well. So get prepared, everyone. All right, so estimating prevalence, I've just popped the equation up because I feel like I had, you know, people want to see an equation. No, they don't. No one ever wants to see an equation. But the prevalence is estimated by the number of people with the disease over the total number of people in the population. So it's a pretty simple formula, pretty straightforward if you have those two numbers. The real difficulty lies in getting those two numbers. Once we have them, the equation's easy. So thinking about hepatitis C, and if it's defined as the total number of people at risk, who would we include in the denominator if we were trying to estimate the prevalence of hepatitis C? Would we include the whole of Australia, specific subgroups? What are people's thoughts?
People are all thinking, Josh.
Don't be afraid. Don't be afraid to jump in. No wrong answers. So I think this is a nice opportunity, like in a small group, to kind of put some thoughts forward, because I think this data is commonly presented, but we don't often get the chance just to kind of pull these two things apart, the numerator and the denominator, and talk them through. And so if you've ever asked yourself this question, now's a really good time to kind of just throw it in.
We've got two, Anna. We've got one, the total population of Australia.
Yeah.
And another one is the people at risk of contracting the disease.
Yeah. So for hepatitis C, who is at risk?
Yeah, I'd go with total.
Yeah.
Everybody in Australia is at risk of contracting hepatitis C.
Yep, I definitely agree with that one.
Everybody is at risk.
Everybody in the population. Okay.
I would say not quite everybody. I think there's some people who have no risk of contracting hepatitis C. And if I put them in the denominator, they dilute the effect. What do other people think?
You don't really know who's at risk, do you?
Well, what's at risk? What's a risk for hepatitis C?
So Morris has just put people who inject drugs. Yeah.
So
prisoners, people who inject drugs, people
from high prevalence countries.
Yeah, high prevalence countries. People that had blood transfusions before the late 80s.
So remember, go back to fundamentals.
Tattoos.
How do you contract hepatitis C? To contract hepatitis C, we know you need blood to blood.
Mm-hmm.
So exactly, blood to blood. Who is at risk of blood to blood? So you have to have done something that puts you at risk. So we know that's medical procedures, injecting drug use practices, sexual contact. It can be household sharing, but that's really low. So I think, Gab, your question is, those are all the risk factors, right? Let's just spell it out really plainly. I'm not talking complex language here, really plain language. How do we know? So Gab, I think your question is, how would I know if someone's had a blood-to-blood exposure? How do I identify them?
Yep.
We can't. We don't know.
And can I just add, I think this is where sentinel data really comes into play here in, NSP surveys and, bloodborne prison entrance surveys, and really using that robust methodology to capture at certain intervals throughout the year to apply that to that population of prevalence, risk behaviours and the likes.
Really hard, Troy. Almost impossible, because again, they're selected samples. So essentially,
Yes.
you need to be really confident that you have a group of people and you've captured all of them, and all of them have told you, or you have evidence for all of those people that they have been at risk of blood-to-blood exposure.
Yeah, I guess there are limitations there. Yeah.
We don't have that. It's
You've
not.
only got people that access NSPs and not pharmacies and the likes, and yeah.
It's absolutely non-existent. So the number of people in Australia who inject drugs is unknown. Totally unknown.
Oh,
Yeah. So go, Gab.
sorry.
No.
Especially when you're talking about behaviours that are illegal, or that people feel shame about. Heaps of people aren't going to just put up their hand and go, yeah, I've done that.
Yeah. So the prevalence of hepatitis C in Australia is unknown. We have estimates, we have good estimates, we have very good estimates, we have modelling estimates, but it's unknown because we'll never know the population for definite, the population at risk. And that's okay. That's just how it goes.
And too, I remember a couple of years ago, we went from 150 million people estimated to be living with hepatitis C, and we went down to 71 million.
Globally?
Yeah, it happened overnight. And
not Australia.
Yeah, it was because they started, and I think Robert's put a point about this in the chat, that they were saying antibody positivity is an estimate of prevalence, but then they changed it to RNA positivity.
Yeah, that's a really good point, Jackie, because then we have this additional complexity in hepatitis C that gives us all migraines, which is exposed and viremic. And what are we interested in? I think we're interested in all of it, but I'm a surveillance nerd, right? And I'd be interested to know, are other people interested in all of those things or not really?
So you're interested in exposed and viremic?
Yeah.
Margaret made an interesting point at the presentation at the Australasia Viral Hepatitis Conference a few weeks ago, where she talked about viewing hepatitis C testing as an event. So it wasn't just the antibody result, it was the antibody result, and if it was positive, plus the RNA result, either negative or positive. So you need both tests to make up the actual testing event. The question then becomes, what's the primary thing that you should be notifying on? Currently, we're notifying primarily on the antibody. Should, in fact, we be primarily notifying on the RNA result?
Yeah, so Margaret stole that idea from me, I reckon. Margaret talks about it in terms of a complete testing event. So what it is a complete testing event gives a person a diagnosis. So that's about the person receiving that complete care and understanding their diagnosis. And so then for that, how that rolls into notifications is that currently we have surveillance of test results. We don't have surveillance of a diagnosis. An antibody test result that is positive is not a diagnosis. A full diagnosis is, I think this is what you're saying, Robert, for everyone else's benefit. A full diagnosis would be an antibody positive test followed by an RNA test, and that RNA result, whatever that RNA result is then the diagnosis. And so the argument is, should that formulate the basis of a notification? So our notification data and what we're surveying is then diagnoses, and the diagnosis could be exposed plus or minus cleared or treated, or exposed and still viremic. So instead of this vague, unspecified and newly acquired, we would have, I think this is where you're going, Robert, or maybe I've just run too far away with your ideas. We would have a notification system that actually is more informative in terms of what we're trying to achieve with hepatitis C, which is diagnosing and treating people.
And more dynamic. So we don't simply accumulate numbers, but we have a more dynamic approach to the data.
Yeah, so it's using the data and acting on it in a timely manner. I mean, yeah, most surveillance people are little bowerbirds like me, so we're quite happy just to keep collecting and collecting and collecting things. But I think the argument now is, well, I think enough's enough. You know, we've kind of collected enough information now. I suggest you get out of your chairs and do something with it. That's kind of where we're at with hepatitis C surveillance. I'll hand back to you, Jackie and Josh.
Oh, and I was just going to ask, is there an example of where that is happening in other infectious diseases?
Yeah, so we've had a long, we've had a 30-year history of executing that reasonably well in HIV. And I think HIV public health response could see the benefit of understanding someone's actual linkage into care. So they did actually do that. Very, very resource intensive. So we know it works. And I think we're just trying to then think, okay, how do we do this for viral hepatitis?
Yeah. Okay.
Yeah.
And as Nicole says, that's the point of the checks.
Correct.
That is coming out of the work out of Doherty and DHH.
Yeah. Yeah.
Fabulous. Thank you.
Thanks, Josh.
Thanks, guys. Did anyone else have any thoughts? I don't think so. Well, actually. Cool. So this is just a visual representation of prevalence. I feel like most people are sort of pretty comfortable with it at the moment, but here I've got some icons. We've got a population of 16 people, with 3 of them having the outcome, with a prevalence of 19%. Pretty straightforward. Moving on to incident. Oh, no. Prevalence in hepatitis C. Okay, so this is a direct quote from Anna's hepatitis C annual report from this year. The quote is, among annual needle and syringe program survey respondents tested for HCV RNA, positivity declined from 51% to 18% between 2015 and 2019. So this is an example of using surveillance data to answer a question and present results that can be used to track our progress towards elimination. I've put some questions here. So this is, again, kind of trying to get people's thoughts and start a bit of a conversation. But the question is, what's the denominator in the proportion that we're presenting here? So who does it represent? We know that it's the respondents from the annual needle and syringe program survey, but who are these people? We're asking a subset of people. We're asking a selected group of people these questions. And so who is that select group? Nicole said, yep. So it's people who use NSPs and inject. Yeah, I would agree with that. But it's also, yeah, it's people who, if you think about the way that the survey is designed, it's people who go to an NSP and then they get approached to participate in the survey, and then they participate in the survey, and then they complete the entire survey, and then they get a sample taken, and then that's tested, and then we get an RNA result. So we've kind of selected this sort of subset of the group that we're trying to measure, which is fine. It's just important to kind of be mindful of who it is that we're actually measuring. Anna, did you have any thoughts?
No, keep going. Yep, all good.
Morris has said, so it is only those who participated in the survey. Yeah, exactly right. Which is fine, but it's, you know, it's just being mindful of who it is that we're actually measuring and what it is that we're presenting. Yeah, and so the numerator in this case would be of those people who tested positive. So everyone in the numerator needs to be part of the denominator, as we know. And then we can use this information to do stuff like track our progress towards elimination targets and look to see if there's increases or decreases in prevalence over time from this data. All right, moving on to incidence. So as we said before, an incident case is a new case of hepatitis C. I've put 3 ingredients. I've called them ingredients to identify an incident case. So identifying an incident case is actually quite challenging. What we need is the time period of observation. We need to know when they started and when they ended. We need to know their hepatitis C status at the start of the observation period. And then we need to know who was positive at the end. So without the real tricky thing is the second ingredient. So the difficulty here being that if we test a bunch of people and we find a bunch of positives, we can't say conclusively that that is an incident case, because that's just the first test event that we have for them. That's our first positive event. What we need to have had in surveillance is a prior negative and then a subsequent positive in order to say that it's a new case of hepatitis C, which is, if you think about it, logistically a bit of a nightmare to try and get that information and be, have that person also across the whole observation period. So can anyone think of any, this is the conversation starter, can anyone think of any studies that can capture all the information needed to define an incident case?
I think we've terrified everyone with epidemiological terms, Josh. We've really killed our audience today.
I'll attempt to make it not dry.
Utterly failed.
It'd be if, and this is a random guess, sorry, I'm losing my voice. If someone was, had testing when they were admitted to prison, and then testing at a later date, whether it was at the end. I don't think they actually get testing prior to.
No.
Being, no, that won't work, will it? It's a controlled environment, but it's not a yeah, no, that won't work. Just talking it out.
No, go for it. I think talking it out is really helpful. I think that's the way I think as well. So at the moment, I'm sure people are kind of like churning through the same thing as well. So yeah, this is hard. This is a challenge, but you might have seen incidence estimates presented or new cases presented. How do they do that? Or can you do it in your own data? So I know a lot of people on the call have their own projects and their own settings and their own clinics. Do you have this data in your own projects?
Anna, can I just ask a question? Can you use disease progression as a marker of a new case or an older case?
No.
No.
What we're looking for first is diagnostic testing.
Right.
So we can use disease progression to think about attributing transmission. That's a possibility, pretty complex, but let's start with the basics. So who on the call has access to data or knows of a study where they collect diagnostic testing, so antibody testing and RNA testing and identifiable information, so a person's name or date of birth?
Hi everyone, it's Kate Patton here. I joined in late, but hopefully everyone can hear me. I'm just going to have a bit of a stab in the dark. I am quite new to hepatitis, so I work for the New South Wales Ministry as a policy officer. I've been in the role for about 6 months. What about so people coming into Australia through the immigration process who have to be routinely screened for bloodborne viruses? So they're screened when they come into Australia, and then for whatever reason, 2 years later, they enter a health service and they declare that they've had some kind of indicator or risk behaviour for hepatitis, and they get tested, and then they come back as positive, but they have a record for when they entered Australia for that bloodborne virus screening as a negative result. Would that be an example?
Yeah, good example, Kate, and it's a really good example. And the only missing link is who holds those two pieces of information. So who has the negative test result data and who has the positive test result data? Because the negative test result data could have been done by the health service that works for the federal immigration. And that negative result is not reportable because negatives aren't reportable. So who immigration might have that data. Then the person might go to a GP and the GP owns that data and then they test positive. So how do we get those two pieces of data together? But yeah.
Yeah, it's tricky, isn't it?
It is
especially
tricky.
when you talk through it.
I know. So what we're looking for is the simple example is where is two tests held in the same place, an antibody and an RNA test event, and then a repeated antibody and RNA test event within the same.
Well, they're held by the Commonwealth. They're held between PBS and MBS.
Yeah, exactly, Robert. Do you have access to that?
Good luck with that one.
Exactly. So you're right.
Yeah,
The MBS has that data and they won't hand it over to anybody.
Yeah. They won't hand it over to jurisdictions. So
they might do, yeah. But what about research studies?
We've tried.
Yeah. Is anyone aware of a research study?
Yeah, I think the Sharp C study at Kirby kind of tackled that a little bit because they were looking at reinfection.
Yeah.
So they were looking at following people from their initiating of treatment and then following them through after completion of treatment.
Yeah, correct, Amanda. Exactly. So what's the resources involved in executing that?
Well,
substantial.
I don't work for Kirby, but I imagine it's a lot. So we were a site for Sharp C for a short amount of time. So it involved point of care testing. I think we were doing it was supposed to be every 3 months if that was viable, which really it wasn't really viable for our population group to test to engage people that frequently. But that's, I guess, the nature of research and getting reliable data.
Yeah, correct. Yeah, so that's a cohort study, right? So a subset of people that have to be found, be consented, and have a whole bunch of data collection. They have to have antibody and RNA testing at periodic intervals. If you miss the RNA test, you might miss a diagnosis. And so that's a very kind of specific way to be able to collect incidence. There are a couple of cohort studies. So Sharp C is one of them, Stop C is one of them, Supermix is the one out of Burnett. So Supermix has 12 years of follow-up with annual bloodborne virus testing. So we can get a negative to positive result. There's Atlas, which is the network of Aboriginal medical services that does routine extraction out of GP software. So you can collate a person's testing history, and the same with Access. So that's a sentinel surveillance system again, where you extract routinely collected testing data and you can put together someone's testing history to be able to see. Really difficult to do.
And Gab's just said is pregnancy and antenatal screening. Is that another opportunity? I guess you're relying then on the woman, the pregnancy.
Yeah, so thanks, Gab, for bringing up what's been giving me a migraine now for a year in Access data, which is pregnancy screening. So pregnancy screening is incredibly problematic. It's very good for patients. So in 2016, the guidelines changed. So the antenatal guidelines recommend routine testing because of access to DAAs, because there's a benefit in screening women now routinely. So routinely women do get screened. So you are correct. It's an opportunity to pick up new infections, and it does do that. The massive, massive problem that it's given me is it now inflates the denominator, because a whole bunch of women who have no risk for hepatitis C are getting tested. As you can see, Josh's equations, which is, I know people don't like equations, but it's how we think. Because now if you imagine a whole bunch of people have just flowed into that denominator, and they don't show up in the numerator because they have no risk for hepatitis C. So pregnancy screening is good for patients. It's terrible for surveillance.
Nicole, do you want to ask your question still? Nicole's just asked, this negative test result and, why the definition of an incident case having a previous negative test result.
Yeah, it just seems like, obviously I'm still new and I'm still learning about Hep C, but from my mindset, it seems like a terribly unreliable way to define a new case if the people haven't previously been, tested for Hep C, that there's actually a whole lot of what we class the department as, like new or active cases of Hep C. It just seems like if there was a prevalence going on and the people had never been previously tested for Hep C, and the doctors didn't know what the exposure site is, we'd never know about clusters of Hep C happening at, I don't know, say a tattooist or something like that. It just seems very odd to me that such a difficult thing to obtain, such as a negative antibody response within the, I think our definition is the 2 years. It just seems silly that that's the marker for defining an active, and I was wondering why that is, what the background is for it.
Yeah, you've put a lot of issues into one question there at once.
Sorry.
So remember, the purpose of surveillance is to prevent infections. That's the goal.
Yeah.
So if you get notified as antibody positive and you have no testing history, and the GP notifies you as newly acquired based on your epidemiological indicators. So you go to your GP, you come up positive, and Jackie, as you're aware, we're talking about something that did happen in Melbourne. So you go to your GP and they say, you've got hepatitis C, you must have injected drugs. And you say, no, I did not do that. So then the GP has the option of notifying you as a suspected newly acquired case. And you do flow into the enhanced notification, where they look at kind of investigating your case, even though you don't have a previous negative to fit the newly acquired definition. There is scope in there to try and do what you're alluding to, which is effectively to prevent nosocomial acquired infections. So there's a hierarchy of risk. So when they investigate, they'll say, do you inject drugs? And the person says no, and then they'll raise their eyebrows and then look at your risk and see if effectively you are what is, a current transmission. And again, you have to remember the resource setting. You have to kind of make a hierarchy of decisions and surveillance as to how far you can go. So that's kind of the notifications and follow-up and prevention of transmission purpose. For the purpose of, that's why there's case definitions, but that's why I think there's a bit of leeway in terms of this enhanced notification, speaking to patients, speaking to GPs. In terms of incidence, you then have to be fairly strict about making sure people don't have the disease when you start following them to really meet your case definition of incidence, because you need to understand if new transmission is occurring, because that's what you're trying to prevent. So you actually don't want to mix up people who currently have the disease with people who are acquiring the disease, because your actions differ. Someone who has the disease, you act differently to someone who is acquiring the disease. And you have to kind of juggle a lot of balls at once, right? We have to look after the people who have the infections and act accordingly. But if there is a whole lot of people churning through new infections, we have to do something a bit more immediately. So that's why incidence is really important, because not only does it have a component of time in how you measure it, it has a component of time in how you act. If incidence is happening very quickly, you need to speed up what you're doing. That's why the time component of incidence is really important. And that's actually why you need to know when they did not have the disease.
Okay. Still leaves me probably with more questions.
That's fine.
I understand what you're saying, but I guess, I've been looking at the data, the surveillance data from the department, and the potential things, flagged as potentially active or potentially new cases.
Newly acquired.
Yeah, sorry, newly acquired is so minimal.
Yes.
Yeah, I just think,
because it's very hard to get the evidence they need for newly acquired. Yeah.
Okay.
So there is fail-safes in there.
Sorry,
I was just going to say, and again, you're just talking about exposures. You're not talking about cases. And it really, my observation is it works well in prisons, but it doesn't work well in the community.
Yeah, it's challenging, but I think always, Nicole, remember, and I used to do this job, is there is a human behind it. So there is a human person applying those case definitions and doing the follow-up. And, they've got that ability to investigate further and think about that, how that case definition does actually work. And, is it really likely this person has actually acquired this really quickly? So we need to act really quickly. So there are humans behind notifications.
Yeah.
Can I ask, is there a specific reason why there's the 2-year previous negative test has been the standard for newly acquired. Is there a reason for that, or is it just an arbitrary?
I don't know, actually. Yeah, I don't know. I think it's arbitrary, but I don't actually know.
So all newly acquired cases are always investigated with enhanced surveillance.
Generally, yeah. So if you received a laboratory test result, so the first step is you investigate their previous lab result history, and if you found a negative, you can classify them as newly acquired. And generally, they do enhanced notification of newly acquired cases, apply a hierarchy of risk, because they are effectively looking for a risk to the community.
Mm. Mm. Very interesting. We never read a surveillance report in the same way, are we, people? Any other questions? Josh, I think you're almost through your slides.
Yeah, we've got a couple more left. We've got another one of those sort of visual examples. I realized I should have put the visual example before the conversation starter, but live and learn, I suppose. Here we've got on the left, we've got the start of our time period, which is the beginning of 1 year. We follow up we have one person who has Hep C at the start. We follow up these people for the entire year. We've got a full year's worth of testing data from them. And then at the end, 4 of them have Hep C. So we've got 3 incident cases. So we were able to test all of these people at the start. Let's say we tested them every month for 12 months, and then we tested all of them at the end. So, and following up these 9 people for the entire year to show how difficult it can be to estimate incidence, which, as we've discussed, I think everyone has got an appreciation for some of the challenges with estimating incidence.
In the case of Hep C, would we specifically need to define whether that was antibody positive or RNA positive? Yeah, okay.
If we were, yeah, because well, I suppose you can report incidence as RNA incidence or antibody incidence as well. But you wouldn't start with antibody and then move to RNA.
Josh, did we miss your equation for incidence and the denominator?
No. Well, yes, there was none. You can go back on mute, Taffy.
That was me. I take responsibility. I don't like equations, and I let them put one equation in, but I said no to equations. Come on, people. Settle down with your equations.
Relax. Thanks, Jackie. Thanks for backing me up. Using incidence in hepatitis C with that conversation before was so good. I'm so pleased with how that went. And also I feel like a lot of these questions have already been sort of touched on or answered. The first point is really kind of intuitive but important, which is that as we continue with hepatitis C interventions and we continue funding projects, we should see incidence going down. And another point is that as incidence goes down, all of these challenges that we've been discussing are going to become more and more pronounced. And it's going to become harder and harder as we get closer to elimination to accurately measure incidence. How is it useful? I feel like that was the kind of topic of the entire conversation before. So,
Josh, can I just ask? So we have this figure of 6,000-ish new cases per year in Australia. So where does that come from? Now I'm questioning where it's all coming from. And if you say it's modelling, Anna Wilkinson, I'm going to question it even more.
She's not going to not say it's modelling.
Because that...
a lot of it is modelling.
Based on...
A lot of it is modelling multiple studies, using data from multiple studies cumulatively. So that's some of the work that Anna Palmer's doing. And then there's the work that Anna Wilkinson's been doing with Access, which has been using the Sentinel surveillance data to measure incidence. And it's really just, yes, it's all of this kind of information being aggregated and informing estimates of incidence. but it is tough.
Jackie, oh, sorry, Josh. Jackie, are you talking about the Kirby surveillance report numbers?
Yeah, yes, Troy, I should be able to reference my 6,000 figure, but it's just one of those, it used to be 10,000 and then it's dropped to 6,000. And I know that, you know, in order for us to, obviously we need to treat more than 6,000 people per year to be able to see the prevalence. Oh God, I'm so scared about using these words now. The prevalence going down. But you can combine, yeah, so you get lots of different data sets and you average them out, essentially, with a big calculator.
And for the data sets, are we using specific subpopulation data sets? Or are we using the general population? Like, I know that's quite a broad question, but, you know, if our incidence is this 6,000, what's the denominator? Like because for hepatitis C, like, you know, there are risk factors and there are indicators. So are we using subpopulations that fall into that and then taking into account that some people will fall outside of that and using some of those figures and putting it all into one big bucket? Like,
good question, Kate. You are correct. It is using data from Anna Palmer's work, predominantly uses data from cohort studies of people who inject drugs. So we've got data that measures real incidence, and then we match that to data that's also observed, which is something like notifications. And then you add in the kind of the arrow in between to say, okay, if this is the end result is we've got this many notifications, so we know this many people have some kind of antibody exposure. How did we get to that point? We got to that point by this many people having had a new infection, of which this many would be people who inject drugs. That's how they inquired it. And then what they actually do is they actually kind of like chop a little bit out of that, because they consider primary prevention, which is actually really important, because we can't just say this is, you know, this is, if we take a population of people who inject drugs, that they're going to acquire hepatitis C. It's not true, because a proportion of that population accesses needle and syringe programs and effectively puts their risk close to zero. So you can't kind of consider everybody in people who inject drugs population as having the same risk. It's not true. So Anna Palmer's work actually accounts then for use of needle and syringe programs and primary prevention. And now we also have to account for secondary prevention, because some of those people who inject drugs may not access needle and syringe programs, may reuse needles and syringes, may be at risk of hepatitis C. However, they're treated, so they're not viremic. So we need to kind of account for that as well. So it puts the pieces of the puzzle together, takes little bits of information and fits them together in a way that actually makes sense to kind of for what we're seeing in the real world. So a lot of the work we do, you can always kind of take it, Kate, as really being among people who inject drugs, because in Australia, that's what we're focused on achieving first.
Thanks, Anna.
No worries. Back to you, Josh. We're almost done.
We are. We've got a summary slide, which just sort of outlines some of the key learnings from today. So the fundamental role of surveillance is around monitoring and responding to infectious disease epidemics and outbreaks. We have lots of different forms of surveillance. So it's not just notifications, but it's also sentinel surveillance and behavioral and biobehavioral surveys. And we can use surveillance data to inform not just our progress towards elimination, but also the planning and implementation of projects and interventions with hepatitis C. So that's it for the slides. It's exactly 11 o'clock. So thank you so much, everyone, for coming, and thank you for contributing to the conversations. It was really wonderful, and I'm really pleased with how the conversations went and all of the questions.
Josh,
I can stick around for 5 or 10 minutes.
Sorry, can you just see if you can launch the poll? I can't do it for some reason. It's not it's saying I don't have permission, which we'll be talking to the computer about.
There we go. I've just launched the poll.
Because you have all the power.
It's only 3 questions.
3 questions, we'd be really, really grateful. I just want a massive thank you to Anna and Josh for this session in particular. Very quite, it's complicated, but I feel like I've got access to some information that's, made me have more questions, which I always think is a really useful activity. But also a massive thank you to Josh for leading these workshops over the last 6 months or 4 months, whatever it was. It was a great brainchild that he had at the end of last year, just before Christmas, when we were all about to go on holidays. And we're like, yeah, fantastic. What a great idea, Josh. Anyway, we've done it. They are resources that are available through the ECA Australia website. And really massive congratulations to you, Josh. We're really well done. So if the whole research thing doesn't work out, I think you can be a teacher because you're. Thank you all so much for coming and contributing to such a great conversation. We look forward to seeing you all soon.
Thanks, everyone.
Thanks, guys.
Thank you. Pause the recording.
So did that launch, that poll?
Yeah.
I didn't see it.